My name is Jody Gutkin. I am a physical therapist. I have been practicing for over 25 years in the field, and I love all aspects of it. Particularly for this topic, I've worked in the outpatient setting. I've had the opportunities to work with different organizations, developing education training programs for their employees, as well as with my own patients, looking at return to work and workplace modification. I've worked in many different practice settings. I have also completed my Certified Ergonomic Assessment Specialist certification, so that gives me a little more insight into what we're going to discuss this morning. I love practicing physical therapy, and I also love teaching physical therapy. So I am also an educator in physical therapy education down here in Florida. So I look forward to sharing some of my experiences with you as we work through our topic for today. Overview of our course that we are looking at this morning. As I mentioned, we're discussing workplace modifications, and the specific settings that we're discussing is pretty much everything other than the office environment. If that is a topic that you're interested in, I do have a course on office ergonomics. Some of you may have been with us previously for that, or that is available for the office setting. What we're going to look at today is every other workplace setting, whether it's a factory or maybe a business type of setting or a construction site. So we'll talk about those different work environments and what do we need to be aware of for injuries that may happen there in terms of cumulative trauma, and then also for modification for return to work for our patients. As we go through, I want you to not only consider today individuals who may have sustained an injury at work that you're rehabilitating them for, but also consider that a lot of people are weekend do-it-yourself project individuals. So they may be participating in activities that could be exacerbating the symptoms that they're experiencing, or that could potentially be inhibiting your rehab progression and activities that they want to return to. So think of those do-it-yourself projects also. The information that we're going to cover today, we'll spend our first hour kind of looking at some of the data and general information related to workplace injuries, give you an understanding of how OSHA looks at this field. We'll review information from OSHA, the National Industrial Occupational Safety and Health Organization, Bureau of Labor and Statistics, Department of Labor information from several different countries, United States, Canada, and all of these resources that I utilize to compile the data and information we discussed are in the references at the end of the course. So the first hour will give us a sense of what we are looking at in terms of workplace settings and what we should be aware of. Our second hour, we will look at the specific pathologies that can develop and some of the contributing factors. And then in our final hour, we'll look at specific modifications. So if your individual is working on a farm, what should you be aware of? If they're on a construction site, questions should you ask, and activities should you think of incorporating into your rehab? So we'll look at all of that information. As always, any information that you utilize when you go back into the clinic from this course, you want to apply within your federal, state, and professional regulation. All right, so enough of all this up front. Let's get to the reason you're here and start covering some content for you. What we are going to take a look at are, as I mentioned, not only individuals, how we can modify their workplace if we're treating them for a work-related injury, but also looking at individuals who maybe they are just coming in for that Achilles tendonitis that they developed, and they also happen to be a manual laborer. We're going to want to be aware of that so we can incorporate activities in our rehab so that they can return to work. This is also information that you might choose to utilize if you're looking for opportunities to be more engaged in your community or expanding your practice. Doing workplace assessments or education might be something that you're considering, so we'll give you some ideas that you can apply this information in those settings also. What we first want to understand is really how broad this topic is. It's immense. To give you a little bit of the historical perspective, about 45 years ago, OSHA came into existence. The Occupational Safety and Health Act was implemented with the real goal to minimize workplace injuries and deaths, to look at holding work sites accountable and employers accountable to make modifications to help limit the risk to their workers. And to give us a sense, the Bureau of Labor and Statistics reports that there are about 4,500 workers killed on the job annually, which is a staggering statistic when we think about it. And not that we have much of an impact in preventing those types of injuries. It's something to be aware of, though. We are considering that the number of workers who just have injuries on the job is around 3 million workers. So it's significant. Occupational injuries can run from anything with, let's say, a needle stick if they're in the healthcare setting, to scrapes and bruises, or to something more significant like limb loss, hearing loss, or other chronic types of conditions. We see that in 2014, OSHA actually put out a statement saying that workplace injuries and fatalities are unacceptably high, that what they have been doing wasn't really working as well as it needed to protect workers, that there was still too much exposure and hazard risk occurring, and that the cost of it is immense. If we look in 2012, the cost on society of workplace injuries was almost $200 billion, according to the National Safety Council. To put that in perspective for us as healthcare workers, that's on par with the cost of Alzheimer's and dementia, as well as diabetes, during approximately the same time frame. And when we think about workplace injuries, we have things that can be done to help minimize the risk and cut down on some of that. When we look at this data, we're thinking beyond just the numbers and the economic cost. I love the statement that statistics are the people with the tears washed off, because for every dollar that is spent, that may be coming out of someone's pocket so they can't be putting food on the table. We are considering that the impact on the families, if someone is unable to work, a spouse, well, maybe the other individual in the household needs to take on a second job. Or maybe they are having stress in their relationships now because of their injury. So that takes a toll on the well-being of the entire family. It's going to stress the workplace itself, because someone at the job then needs to pick up the slack if they're down a particular worker. So there needs to be a way to decrease the risk of these injuries. And if we compare to other countries, I looked back, and in the 1990s in the UK, they implemented very strict standards for construction sites to address this concern of workplace injuries with those particular workers. And if we look at just fatalities in that setting in the UK, they have a third of the fatality rate that we have here in the United States since they've implemented those guidelines. So they're just in construction alone, they have a quarter of the incidence of workplace injuries being reported. So there are models out there and things that can be done. And OSHA, our country, is taking a lead in implementing some different standards, but the cost is still immense. And if we look at who is bearing the cost, the intention was that it was workers' comp was going to make up for this, to take the burden off of the family and off of the individual and the business. Unfortunately, that's not happening. If we total it, we see that approximately 63% of the cost of these injuries is borne by the individual family from out of pocket or their private health insurance. That through government funding is another about 16%. And then workers' comp is just kicking in for about 20% of the cost of this. So the impact is significant. And OSHA even says that the system is just not working the way that it should. So today we're going to look at ways that we can help improve it, and what employers are doing also that we can tap into to maybe break this cycle of workplace injury, particularly for repetitive trauma type of injuries. As I was working through the research, a population that came to mind that was brought up were our temporary workers. Those of us particularly in Florida or other states where we have a shift. We have our snowbirds down here. In other parts of the country, you may have other terminology, but where you have more of a seasonal workforce. A lot of facilities, think about it, even at your own facility, if you bring in a seasonal worker, they're expected to hit the ground running, right? How much training does that individual receive in the specific, even physical work environment? Where are things located? How much safety training do they receive? Because employers are kind of outsourcing to other companies to bring these temporary workers in to take the burden off of them. Well, these workers then do not necessarily have the same training, and we're seeing that it places them at a greater risk of injury. They're also a lot less likely to complain if they have an injury, so then it can make it turn into something more chronic. So something to consider when you're interviewing your patient. Find out what their work setting is. Not that you need to be intrusive to see if they're a temporary worker, but see if they've received the training they need on body mechanics or just awareness of equipment that may be available to make the job easier. It might be part of our interview process as we're looking at the work setting for the individual, because it does impact their overall recovery, even if we're not rehabbing them for a specific workers' comp of injury. OSHA, of course, and the U.S. Department of Labor said that, what is the solution to all of this economic burden and individual stress that it places? Well, to prevent the injuries. And yes, that makes sense. It would be nice if it was that simple. And they have taken steps to put guidelines into place in 2015 to hold employers more accountable for preventing injuries in the workplace. And the way that they've done this is through enhanced record keeping, and workplaces are required to keep logs of different injuries. And this is something, if you are looking at working with a company to implement different programs, this is the kind of data you want to ask them for. That every incident where someone has restricted ability to work in any way, where they're unable to perform their specific work tasks, or they need to seek medical care, anything beyond basic first aid like a Band-Aid, if they need to seek any additional medical care, the employer has to keep a record of that. Everything significant from amputations to back injuries, fatalities, but even if we look at needle sticks and other exposures or injuries that can occur. And what they've said is now the reporting that has to happen is anytime there's one incident where someone has to seek medical attention, that has to be reported to OSHA. They have telephone and online reporting now, so within 8 hours, OSHA has to know about this for fatalities, and within 24 hours for any non-fatal types of injuries that they're keeping track. They're saying employers can no longer wait until we have sentinel events where there, is at least 3 cases of significant injuries. They're saying we want to know about every case that happens to force the employers to look at it, to look at workplace exposure, and look at not only chronic illnesses that can develop, but even the accidents, the slips, the trips, the falls. And this can be an opportunity for employers to make modifications to limit these types of injuries. Workers' compensation, right? That's like the elephant in the room when we talk about workplace injuries. And something to think about when we consider this is there has been a shift that's been noticed that not all individuals who sustain an injury even realize it's related to their work, so they may not be filing under workers' comp. They're actually seeing that less than 40% of individuals who do have a pathology that leads to an injury at their work site from their work interaction with the work equipment or the tasks that they're performing, less than 40% are actually reporting and claiming under workers' comp. So we are clearly seeing these individuals even though they don't have that label or funding attached to them. It's important to recognize this because, again, our questions in interview, consider in your intake, how much do you ask your patient about their physical work tasks? Because it does come into play and it's something that we need to consider in our rehab for them. It also helps us identify trends. Again, if you're working with an organization, it's an opportunity to step in because everyone is not reporting an injury that occurs at work. For example, one year a student, she worked in the hospital laundry room as she was going through school and prior. And as she learned more about body mechanics and injuries and repetitive strain, cumulative trauma, she said, she worked with her boss and started to implement some in-servicing at her site and started saying, well, instead of getting this kind of cart with a horizontal handle, why can't we have a cart with a vertical handle? Or why can't we rotate tasks instead of everyone, someone's on dryers, someone's on washers? So there are opportunities if we talk to our patients and see what's really involved in their tasks to give us ideas of how to simulate in the clinic, maybe to let us know, do we need to be working on muscle endurance? body mechanics, we think of our back, right? We think of the big things first. But think about, shoulder mechanics, wrist and hand. What surface is someone working on? How quickly do they need to perform a task? What kind of endurance do they need? So it gives us opportunities for us to look at what's called near misses. Those instances where someone would have been injured more, but it didn't quite happen. So if your patient performs deliveries and they're delivering appliances, they unpack it in the truck, they have to get it down off the truck, and maybe they're stacking the washer and the dryer to get it in the house quicker because it's raining and they don't want to make 2 trips, or they get a bonus if they get done faster. Well, as they're trying to, move those 2 items, it slips, they go to grab it, and now they have a labrum tear. So maybe they don't report it, or they didn't tear their labrum that time, but over time we can see that this could happen. And finally, when we get them in therapy, we need to think about, they may not attach it to the fact that they're stacking the equipment. We need to look at replicating in our therapy sessions work and asking our patients, how are they performing their job tasks, so that we can institute prevention and control measures to minimize their risk. If you're not able to go out to work sites, right, which isn't possible for all of our patients, maybe ask them with technology, is there an opportunity to take pictures, as long as there's nothing proprietary and it's okay with their employer? How else can they do a video, take a look at their work tasks and how they go through their activities, so that you have an opportunity to look at where you can modify. Because looking at these non-fatal types of injuries is very important as we go through considering our workforce, that we need to recognize that our baby boomers are getting older and they are working until later in life. They're well into their 60s now, and many of them are still employed. So they are not going to heal as quickly. They are going to have decreased musculoskeletal abilities, but still trying to perform the same job that maybe they've been doing for the past 20 years. So as we see in these individuals, that anything we could do education-wise and prevention-wise can help break the cycle for them of injuries. What OSHA actually reports are DART. It's called DART. It's days away from work. And it's either days away from work where the person can't go to their job, restricted work, so maybe they're not working at 100%, someone maybe is more on the desk versus on the assembly line, or if they need to be transferred completely to a different area. And what they're finding is that in 2013, there were 1.2 million cases of injury requiring at least 1 day away from work. That, again, is a significant burden on the individual and the organization. And they projected this out. If we think about the workers that this is happening to, often they're manual laborers. They are not making much over minimum wage. So any small loss is significant for them. So they may be continuing to work even when they shouldn't. Think of it as that patient that you give the home exercise program to, where maybe they're too aggressive because they're overzealous. Consider our workers that they come to therapy and then they have to go to work the next day because they need to put food on the table. Yes, you told them to take it easy on their exercise program or not do too much overhead reaching, but they need to go back to their job, so they're not thinking of it. So maybe consider earlier on in your therapy sessions with the patient to look at work task modification, as opposed to thinking of it as solely a long-term goal for discharge for that patient. In New Mexico, over 10 years, they looked at individuals who had sustained an injury in the workplace, and these in particular were manual laborers, and they followed them for 10 years. And they found that over that 10-year period of time, those individuals lost about $31,000 in income, which is significant if you figure it's about $3,000 a year because of inability to work, or the expense of needing to pay for their own medical care, or maybe they couldn't work their second job because of their injury. It just wasn't tolerable. For individuals that are making, minimum wage, that is significant for them. These incidence trends are things that we need to consider. We need to look at where are the injuries occurring and what should we be considering. So when they look at the different work settings, we've actually done a good job as a society and professionals in educating individuals about their backs, right? Everyone is pretty well aware of that we're using better mechanics with our backs and our lifting. And they've actually seen that construction workers, agricultural workers, where there's a lot of lifting involved, that they have less injuries than individuals in transportation, warehouse work, and the nursing profession. And it seems curious to think about that, but if we look at the fact that transportation workers, there's a lot of vibration stress, warehouse workers are doing a lot of repetitive type of activities, and nursing, we'll talk about that more specifically, what happens there. But we're seeing that in certain professions that these repetitive trauma type of injuries are where most pathology is occurring. If we break it down by gender, we're seeing the same types of injuries occur in males and females, but they're seeing that women tend to sustain more bruises and contusions. And the research brought up the point that if you think of manufacturing plants, yes, here in Florida, there seem to be new ones being constructed all the time, but in other parts of the country, those may be the same warehouses, same types of equipment. Maybe if you're up in the north and they're automobile plants, they've been there for decades and decades when it was more a male-dominated workforce. Now we're seeing females in many of these historically male professions that are physical labor type of professions, but the equipment is built for men. Statures are different. So they may not be able to interact with the equipment appropriately, and that can lead to more pathology. Overall, as I mentioned, we're seeing that there is significant increase in musculoskeletal disorders. That's our focus for today, our cumulative trauma type of pathologies in certain professions. And these musculoskeletal traumas develop based on three set aspects of or three set components that contribute to the development of our musculoskeletal pathology. We have individual risk factors, biomechanical factors, and psychosocial factors. And they all are going to interact to lead to increased exposure risk. Biomechanical we think of first as clinicians. And when we look at the general workplace, we're thinking of individuals that are working in awkward, uncomfortable postures. Maybe they're installing an air conditioner. Excessive repetition. Maybe they are a nail technician. Forceful exertions. They're lifting and moving equipment. These are areas where these non-neutral postures, they're exposed to vibration, different stereotypical repetitive movements can lead to increased injury. Psychosocial factors also play a role in injuries, that they're seeing that this mental piece comes into play, that when there is decreased job satisfaction, there tends to be a greater incidence of injuries. And the other piece with that is when there is mental stress, there is less attention paid to safety. So individuals that are distracted mentally or exhausted mentally, emotionally, not in a positive state, they're not going to make the best safety decisions, or their reflexes, they're not going to react as quickly or be as aware of a whole situation. So that can have a negative consequence of placing them at a greater risk of injury. They're also seeing in the data that when we have this combination of anxiety, depression, not being happy in a position, that this causal relationship leads to increased pain, sleep disturbance, decreased job satisfaction, and again, increasing the incidence of injury. And that leads us to our last section of individual risk factors. What happens with individuals if they are stressed? They're seeing often we go to comfort type of things, whether it's food or it's being less active, just sitting on the couch. That not only does the technique of work habits play a role in injury risk, that an overall individual factors of their general health has a significant impact, because everyone's starting with a different baseline, and then they're involved in the different job stresses on top of that. And employers are recognizing this. We're seeing that individuals who are obese and maybe they smoke also, that's going to lead to an increased risk of respiratory disease. Now they have decreased endurance. So when they're standing on that manufacturing floor working on the assembly line, well, they're going to fatigue a lot faster, move into compensatory postures, increasing their risk of injury. So it places them at a greater risk then, and then it's also going to slow down their recovery. The research is actually showing that this is a very interesting study where they looked at different comorbidities and tried to match up, well, which diagnoses lead to which type of injuries. They attempted to track this. And what they found is that individuals who had ischemic heart disease, diabetes, depression, and asthma, and we could see linkages through those, that they actually had greater incidence of burns, musculoskeletal injuries, cuts, abrasions, fractures, sudden onset type of injuries. And it shows here that there are definite linkages, that the individual is not going to heal as well, but also that these are opportunities of where we can intervene. That for ischemic heart disease, diabetes, even asthma, there are actions the individual can take that they can make modifications to improve in those areas, and then hopefully it'll decrease their incidence and increase the speed of their recovery. How does this relate to us as clinicians? We treat the entire person, that these may be opportunities if you're talking to your patient and they have diabetes, that are they monitoring their glucose levels? If they're working a 12, 13-hour shift, are they taking that break to check their level, have a snack, be aware of that so that they aren't cognitively impaired when they become hypoglycemic in addition to the physical responses. Maybe we need to make a referral to outside sources for the individual, because they're really finding that these causative relationships play a significant role. Maybe it's our opportunity, if we know someone is a low-wage worker, now they're working less hours because of their injury. Do they need a referral to a food bank or some other community source that maybe can help them pay their bills so that then they can focus on their recovery? Lots of opportunities for us to step in, because again, we're seeing when they complete different research studies that these linkages play a role. that we do not just have the opportunity to step in as clinicians with the musculoskeletal. We can refer out because our patients talk to us, right? We get to find out what's going on with them, and we may see the opportunity to make another referral medically or to a community resource. In 2009, the Journal of Industrial Medicine looked at specific body regions to see these causal relationships. And just to give you one example, they found that individuals who were complaining of neck pathology related to their work environment, yes, awkward postures were definitely noted, but they also found that those same individuals reported low job satisfaction, that they felt out of control in the workplace, that they didn't have any influence or any support from their employers. They tended to be female also, which was just interesting. So we're seeing that there are many opportunities to intervene here. Another aspect that comes up is insomnia. As we look at causative factors, we know individuals, right, we're all overworked, right? Everyone is very busy, but for some individuals, they have a condition called insomnia that is not just transient. Not just, oh, I'm a little stressed and overworked this week, it's season, so okay, I just need to get through the next couple months and I'll be okay, I'll get out at a reasonable hour. It's not due to travel or just certain intermittent risks or exposures that we have. Insomnia truly is difficulty falling or staying asleep for 3 nights in a row per week, or 3 nights a week, I should say, for greater than 3 months, and the individual wakes up not feeling rested. So that is going to be more of a chronic problem, and they're actually finding that when we are sleeping, our body is not recovering. That sleep disturbance is correlating to cognitive impairments, mood impairments, and then not making the best safety decision at work because there tends to be a little more impulsivity, unintentionally for the individual. When we do not sleep, that there's an impairment to our nervous system. One researcher said that, our neurons are depleted of energy as we go through the day. And when we sleep at night, that all of those byproducts that are polluting our system are not being filtered out. We're not resetting. So they can't shut down and repair. Our brain is not occurring, so then that carries into the next day for the individual, leading to malfunction. It was an oversimplified way of explaining it, but I think it works for patients to get an understanding. And they looked at many different individuals. One study followed over 50,000 participants, so a large cohort study, and they found that over the 3.5 years that they tracked these individuals, that those that reported sleep disturbance, that they had an increase in the different diseases, obesity, cardiac disease. All of those ones that we said are the comorbidities that fit with increased worker injury. So we're seeing delayed return to work in these individuals also. It has a lot of direct consequences for both minor and major injuries for individuals. That there's this interrelationship between having chronic pain and insomnia, workplace errors, mental disorders, migraines, and then the individuals are in a vicious cycle. If we consider the mechanisms of insomnia, that if we are not sleeping, we see that our immune system has impaired ability to function, that we are having decreased neurotransmitter control of our mood, that our insulin levels become altered, our body is not as responsive, appetite changes tend to be induced, because our glucose tolerance is altered. So that leads to maybe not eating well and obesity, and thyroid hormones can become altered. So when we put this all together for our patients, altering cortisol levels, our stress control mechanisms, that this is an opportunity for us if a patient is reporting that they're having difficulty sleeping. We want to consider, well, how can we step in? We can't prescribe medication, but maybe we're the one noticing it because we see how fatigued they are, or they verbally share it with us. That if you're rehabbing that patient for that bicipital tendonitis or that rotator cuff tendonitis, the inflammatory process is going to be potentially increased in someone who has insomnia. So that is going to limit the healing process for them. They're going to be hypersensitive to pain because they're irritable and they're tired. So we have those effects. We might need to again refer them out, but consider this. Are they not sleeping because of their pathology? That do we have an opportunity there, maybe if we do more patient education on sleeping position? If it is their shoulder, well, you know what, sleep on your side, have your arm elevated, supported on a pillow, and explain to them or try to find out, maybe some of your interview questions that become standard are related to your patient's sleeping quality and quantity, to give you an idea, well, are we having elevated inflammatory mediators circulating in the system because they're not sleeping? So do I have an opportunity, maybe if I reposition them on their pathology, that we will be able to let them sleep better, kind of a what came first. It may be another opportunity for you to step in and improve for the patient. We mentioned that what organizations have to look at is to not wait until there's a sentinel event, to not wait until there is a significant incident. They need to have these plans in place. And most organizations, this is their process now. And what OSHA has done to help spur this process along for them is make it mandatory. That there's this process called Total Worker Health Strategy. And OSHA has told pretty much every organization, there are some smaller companies that are exempt from this, but for the most part, organizations need to look at a twofold process. They need to consider occupational safety and health. So that's looking at the physical hazards and physical environment that the individual is interacting in that could potentially lead to injury for them. And then they're looking at worksite health promotion. So OSHA has acknowledged that, there were these other factors beyond the physical pieces of equipment and the body mechanics of the individual that lead to injury and disease. So they're looking at how do employers help individuals modify their modifiable risk factors and their other behaviors. So this total worker health strategy that is being promoted, it has many ways that it's implemented in different organizations, that it really changes the work climate for the individual. So it has an opportunity to tackle not only the physical stressors, but maybe some of those psychological and other stressors for the individual. It's going to cost the organizations money, but the idea is in the long term, it's going to save them money. So these are some of the things when I talk about this next section is consider when we're looking for those outside referral sources for our patient, now that maybe you're considering other factors, that there might be free resources available at their work that they can take advantage of. We're looking at resources that may be available to our patients and clients through their employer that can help their overall healing, recovery, and well-being. For example, there might be in education classes at their employer on, healthy diet or nutrition. So for that diabetic patient, maybe that's great. It's free. Maybe different prevention programs, even counseling, EAP, employee assistant programs, we may need it sometimes, that maybe the employer allows the individual to go to a counselor a certain number of times for free each year. That may help them manage the mental stress or mental stress from their life that's spilling over into the workplace. We see, particularly for us, that some employers, they offer gym discounts, or health insurance will offer a gym discount. So if you're looking at discharging someone or to a wellness center, if it's not something they can afford, maybe there's that opportunity. Instead of just giving them TheraBand and a program to do at home, well, does their employer or health insurance offer a gym discount? In terms of the organization, also consider that organizations need to use the input from their employees as to the work environment and what is functioning for them and isn't. So for your patients that feel out of control at their work, or that, wow, yes, it would be really nice to have a different work height table, or I need, a new set of pliers that fit my hand because I have a small hand and it just doesn't work. Is there a board or surveys that are done for the employers where that employee has an opportunity to contribute information that it may make them feel empowered and they can assert change, and then it leads to a better psychological well-being for them? So lots of different opportunities maybe we could throw out there for someone to explore if it comes up in our conversation. And again, if you're on the flip side working with the employer, these are the kind of things they should be doing, surveying their employees to obtain information. It's important to give the employees the opportunity to take part in the process, because then it is going to address where the real issues are, and it stops employers from being reactive to situations. We want to encourage them to be proactive. It allows them to, direct funding in the appropriate areas. So maybe consider having employees seek out opportunities so that it doesn't get to that sentinel event level before an employer is going to interact. When we look at workforce and worksite analysis, we're going to not only consider if we have opportunities to consult, not only the actual injuries, but look at near misses that can be occurring. Walkthroughs are great, or again, if you don't have that opportunity, maybe the employee can, FaceTime or make a video or some other way that you can remotely assess their work environment with the employer's consent and the employee's consent, to really see what's going on. I can tell you, way back many years ago in a facility I worked on, we did a lot of industrial rehab, community reintegration. We actually had like a whole little town set up. There was a grocery store, there was, a parking lot, there was like a little automotive area, and we were able to simulate so many different job tasks for these individuals to incorporate it into rehab. That doesn't necessarily exist much anymore, but technology does. So there are other ways we can bring ourselves to the different work settings to help us look at hazard prevention. that we can look at what kind of training is necessary and opportunities to improve. And I'll be giving you links to some different assessment tools. You may walk into an environment or hear a patient, they work in a particular setting, and you may know nothing about it. Do I know what goes on in a poultry plant? Or when I worked with that individual who is, a tomato farmer, I don't really understand that. I'm walking into the grocery store, I'm picking up my tomatoes, they're already available to me. So, you need to interact to really understand what that employee is doing so we can make the appropriate suggestions and problem solve to empower them. There are some tools available that can help you with this. On the last page of the course notes packet, there's a whole page of links to different tools that you can utilize. And one of them are Washington State's OSHA puts out hazard and safety checklists. So it's a nice place to start with these checklists where it will take you through questions you can ask the individual, or they can even take it to their worksite and do a little self-assessment to look at, well, how often are you working with your arms over your head? Or what kind of grip are you using on your tools? And it's a good starting point to gather information. So then we're making modifications from an educated perspective. Maybe it's something you consider using as part of your intake for your patients to get more information on their work site. That's the component of the work site, the physical pieces. When we look at health promotion and those other elements, employers are going to look at adding tobacco cessation, nutritional programs. They're looking at adding opportunities to help improve those modifiable risk factors. And believe me, they're not doing this just of their own volition. This is a big push from OSHA, from the government, for them to implement it. In 2010, Healthy People 2010 implemented this. So do you get those emails from your employer? Join, put a team together and see who loses the most weight in the next 3 months, or come participate in this 5K walk, or you can go to a yoga class during lunch, whatever it is. They're great opportunities for health and wellness that employers, again, because they new to you, but they're seeing the benefit of modifiable risk factors. Having a healthy worker to begin with allows them to function more efficiently with less workplace injuries, that there are these opportunities for them. So again, look and see what your patient may have access to in terms of employee assistance program. Also consider, we can't educate them on what to do, but maybe we could throw information out there that they can investigate. FMLA might be something. If you have someone who maybe they have had a stroke and their family needs to take care of them now. Well, rather than the family trying to squeeze in work and being fatigued and being a caregiver, and then they go to work themselves and maybe they're putting themselves at risk for injury, you might want to say, well, does your job offer FMLA, Family Medical Leave Act, where they can use, some of their time to take time off, to be a caregiver? So looking at everything that goes into play for our patients. Again, we're not telling them what to do, we're not advising, but it's a federal program, and it would be, maybe something we could throw out there that they could consider asking about. So there are different elements that we can consider. Looking at the comorbidities. Does your employer offer free screening, mammograms, biometric screening? Looking at those other factors that increase healing, because we are treating the whole individual, we can definitely point them in different directions. Yes, they're going back to their physician, but maybe we're the opportunity to point them to those other employer resources that they may not know exist until they think to ask about it. In terms of the physical environment, we know we're thinking about ergonomic assessment in the workplace if it's an office worker. Employers, we're seeing changing vending machines even, and this is part of this Healthy People 2010, sorry. We don't make the best decisions for ourselves. I will tell you, I came back from break recently and the soda vending machine was gone. I don't go to it often, But you know, those days you feel that you need that to help you cope with the stress, it had been swapped out. There were all these juices, so I made a better decision. If that hadn't happened, if my employer didn't make that change, I would have gotten the soda. Then, you know, that can lead to the chips had to go with it, and not making the best decisions that can compromise overall health and wellness. So a lot of things that employers are doing are to help target those modifiable risk factors that we know can add to musculoskeletal disease. Because if patients are obese, if they have diabetes, they're not going to heal as well, and it becomes a cycle. Musculoskeletal disorders are where we are looking at to try and modify for our patients. This is the majority of who we are seeing, that musculoskeletal disorders arise when the physical demands of the job just do not meet the worker capabilities. And that could be for many different reasons. We're going to see those overuse type of injuries for our patients. And it's a cycle that leads to their development, that the individual has an exposure to different risk factors, their body fatigues as they're trying to perform their particular task. So maybe their recovery and their repair systems are stressed because of all these comorbidities that we discussed. Continued exposure, muscle imbalance, and then they continue the task. So to give a specific patient example, let's say you have that individual who's packing groceries. And I will tell you, moving to Florida from New York many years ago, but they pack your groceries here for you, and it was the oddest thing. I don't know, I feel like I want to help. And they carry them to the car, and they'll load your car. I have to draw the line somewhere. I don't let that happen, but they pack the groceries for you. Even if you try to do it yourself, right? Someone will come and help, which is a great service. But what I'm doing as they're packing my groceries, and I should be relaxing, I guess, enjoying the service, I'm looking at their mechanics. And I go with paper as my punishment for forgetting to bring my recycle bags in from the car. So I do paper, and then I feel guilty because they take the paper bag and they set it on top of the counter. So, right, paper bag has height to it. So now that kid or elderly person is up here putting the groceries into this paper bag. So they have exposure risk, right? They are impinging the shoulder. They are, leaning to reach things, lifting heavy objects with a long lever arm, and then trying to laterally lean to get it in the bottom of the bag. Exposure risk. We're going to fatigue here, leading to more pathology. Maybe that person is working 2 jobs to pay their bills or to save up for college or whatever it is. So they're not sleeping well. They're not taking their breaks the way they should because they're running from one job to the other. So they're not eating well. So they're, maybe have greater inflammatory mediators in their body. They go back to their next job. Now, you think they're going to the gym and stretching in between and laying in good positions to offset this abnormal work posture? Probably not. So it's going to lead to more pathology, and then they go back to work the same day. So we have this cycle of development that we could need to think of for our patients, because they come to us at the point where now they have pain and they can't work, but they're going to continue to because they have to put that food on the table. So we need to be aware of this cycle and look at where we can break in and do our education as early as possible, right? When we do our evaluations for our patients, we want them to leave with something the first day. And we look at home exercise programs, which are great, but maybe after today you'll consider, is there something related to how their condition is disrupting their sleep that we can do some education or positioning on to help modify? And is there, when we ask, well, what tasks or activities are you having difficulty with, don't just think of ADLs. Think of other either do-it-yourself activities or job-related activities, or if they're a caregiver for a family member or a child, what physical tasks are they involved in that maybe we can give some education and modification on to decrease exposure and break into this cycle. If we look at the top occupations where we're seeing musculoskeletal disorders developing, that it's interesting to see that over time they followed, I think this particular study was published in 2008. So it's a little old, but still very interesting that they followed longitudinally carpenters over 10 years. And they found that over that 10-year period, that carpenters had decreased worker compensation claims. Fabulous, right? There must have been great education and awareness occurring with, this Healthy People 2010 and all of these new guidelines. Unfortunately, when they took the study a step further and they analyzed the private sector medical claims for that same cohort of individuals, they found that there was increased use of their private health insurance. So we are seeing these patients because they may just be going to their private health insurance as opposed to submitting through the workers' comp system. And that's a whole other discussion, many reasons that they choose to do that. When we look at injury rates and illnesses over the time period, so looking from the 80s through to today, this nice red line here at the top is many of us. Hospitals. Hospitals are one of the work settings where there are the most cases of injuries indicated. That's higher than construction, higher than manufacturing, and higher than the national average. We'll talk about why and what we need to do for ourselves so that we're maintained in good functioning ability so that we can help our patients. Musculoskeletal disorders, as we look at them, they're occurring in all these different settings, and the OSHA divides them into specific kind of subcategories. When they look at how musculoskeletal disorders develop in the work setting, it's either going to develop because of a body reaction due to overexertion. So there is the musculoskeletal system and the connective tissue system is going to react because of outside stress placed upon it, and they consider this body reaction and overexertion. It's interesting to note that before 2011, the official definition for reporting of injuries for body reaction and overexertion was bending, climbing, crawling, twisting, all of those things that relate to the back, right? That was the focus. But now the current definition is also inclusive of lifting, pulling, pushing, holding, carrying, and this is important to note, and it gives us an idea of maybe some questions we want to interview our patients about, and then tasks we want to incorporate in rehab. Because holding and carrying, those are isometric type of contractions that tend to be more fatiguing. We need to think about lever arms and where body compensation may occur as fatigue sets in. So we're looking at muscle endurance as well as positioning and lever arms. So this is important to note that now it's recognized that muscle fatigue does play a significant role in injury, and it's something we also need to consider in our rehab. Repetitive motion, we know, with small tasks, multiple exertions, and then vibration also is another aspect where we can see significant injuries occurring because of exposure to vibration, and we'll talk about that and what you should be aware of. The sub-reporting categories that OSHA has, when we look at the different diagnoses almost that OSHA kind of lets you hatch off on, it's an interesting list. Pinched nerve, herniated disc, sprains, strains, tears, we see all of those. The ones that they have added to the list when this shift happened in 2011, they added herniated disc specifically, and they actually added tarsal tunnel syndrome. So when we look at tarsal tunnel syndrome of the foot, we're looking at weight bearing, we're looking at static posture and the stress that causes. So again, it's nice to see an evolving recognition of these pathologies, and again, many opportunities for us to step in, because if we look at all of these different pathologies, what we should see as a pattern here are they're developing gradually over time, weeks to years. It's not usually single event type of pathologies. So think of your food prep workers, your installers, your maintenance workers that are repetitively engaging in different tasks. They're going to develop these different pathologies. And they're saying that since the 1970s, there's been an increase in, physical workplace demands. Higher productivity is required. There's increased use of technology, so maybe more small, repetitive types of activities. And that maybe the workplace hasn't changed, as I mentioned. Our workforce has changed who they are and the physical stature of them, but has the equipment changed sufficiently enough to allow for that? And the new trend and kind of the new philosophy is that it should be designing the job to fit the worker, not forcing the worker's body to fit the job. And one example, this came to mind just this past week as I was speaking to a particular teenager that over the years with different athletic injuries I've treated, and she's working scooping ice cream now. So she has a job she shared. But she didn't share that first. What came up is that she is having cervical pathology. And the cervical pathology is on the left, lots of trigger points, discomfort, it's disrupting sleep, leading to headaches. So as I'm chatting with her, going through what's going on, it's not on her dominant side. It's, we talked about computer setup. We looked at sleep position. Finally, we get to she has a new job and she's scooping ice cream. Well, she's 4'11", and she's scooping hard serve ice cream. So the counter, the bin comes up to a here on her. So she has to get herself over into the bin. She's holding the ice cream cup with the left hand. She's scooping with the right hand. And this awkward posture is creating cervical pathology. After some prompting, right, we need to think about what's my solution? Well, what you need to do is get a step stool. You need to align yourself, lean forward, go in straight. We go over the typical mechanics that should be utilized. And the response was, well, that's not going to work because she has long hair and I have to keep my head this way as I'm scooping because my hair will go in the ice cream bin. So just to show you how we need to get creative a little and look at our problem solving, I said, well, how about a braid or tuck your hair in. We looked at adding stretching, micro breaks to move out of the posture and different things. So taking the time with our patients maybe to simulate an activity and really understand what's going on to see what modifications might fit can give us some better success with our outcomes at looking at modifying that. We know biomechanically that awkward postures are often what's contributing to impingement syndromes, head and neck pathology. Maybe the individual is a painter, and retail workers that are hanging things a lot, impinging in their shoulder. When we look at repetitive positions, that the data is very consistent. And it says that the longer you're in an awkward posture, the greater the risk of injury. So for our patients, looking at the different tasks they perform and then understanding how frequently they're performing it, are there opportunities for them to rotate their tasks? So if they do have to be folding and hanging items, well, maybe they can rotate that. So they're not doing all their hanging at once if it's high overhead. Educating them on contact stress, that if they're leaning against something with their knees, that can lead to great compressive force on the knee. Maybe they'll develop a tendinitis or a prepatellar bursitis. Maybe they can see if they can just wear a pad on the knee as they go through and do those activities. Excessive repetition, high task activities where the cycle time is 30 seconds or less. So we're thinking of our workers who are primarily performing one function for a prolonged period of time, or they are performing that set function. Maybe it's not for very long, but they're doing it day after day. Do we put all of our massages back to back in the clinic? No, because we know we need the micro breaks. So think of assembly line workers, individuals in dental clinics, nail salons, many different professions that where they're repeating tasks. Is there a way that if the employer allows them to rotate tasks or change, with specialization, yeah, we want everyone to be good at their job, but then they're stressing their musculoskeletal system. So maybe there is an opportunity to rotate tasks between different workers or even just switch sides. If they're on a work line, do they have the opportunity just to turn and work from the other side? Because that may just shift the right-left alignment and give a break, even if they're, something simple like that. Forceful exertions we need to look at, that if we think of lifting and carrying and injuring the back, which we do need to be aware of, but we have to look at forceful exertions, particularly with our grasp. Think of you right now, if you're holding your portable device, how hard are you grasping it? Are you holding it with more force than what's necessary? Because if you are, that can place excessive force in the palm of the hand and damage the tendons in the sheaths. They did a study on pharmacists and pharmacy workers, and they looked at the amount of force that they were exerting on the caps, and they found that the majority of the time that compressive force they were exerting to turn the caps was greater than what was necessary to execute the task, and it was leading to the development of hand pathology. Vibration is something to consider, and this is really emerging as a contributing factor. And again, we may not know that someone's job involves vibration. Even now, as I think of it, you may be wondering, what does that mean? A dental worker using the tools, a nail salon. If someone uses a Dremel or a small tool, maybe they're in a veterinary clinic shaving nails, or they're doing some type of construction where they're using the Dremel. Those are our fine vibrations with small work tools that exert a force, because if the tool is moving, that's transmitted into the individual's hand. And what the individual can develop is a local hand-arm vibration syndrome. And that means if it's in one particular area, and specifically in the hand, the individual can develop vibration white fingers. Vibration white fingers happens because that vibration force is transmitted into the hand, and it can create, from the pressure of holding the device as well as the vibration, it can create a vascular spasm of the blood vessels, and in doing so, that's going to disrupt the oxygen and nutrients coming in, the removal of the waste products coming out, and this is then also going to apply a compressive force on the nerves in the hand, decreasing tactile sensitivity, so they may grasp harder than is necessary. There can be numbness, tingling. We know if we have decreased innervation, we have decreased muscular control and coordination, so dexterity is compromised, and in doing so, it's going to increase the pain. So that's a very specific pathology we have to be cautious of. So for small vibration, then there's whole body vibration that you need to consider. Your patients who are working large pieces of equipment, maybe they're a crane operator or a truck driver or a bus driver. Individuals, maybe they're a subway operator. Or they're just using different heavy equipment, maybe to move pallets around a warehouse. These individuals, their entire body is taking the shock of the vibration of the vehicle. Even if it's not visible, it is being transmitted through them. So that can lead to back pathology. And I also want you to consider the shoulder for those patients. Think about, where are they resting their arm? If they're resting their elbow on the maybe window side of the car, or they're medially resting on the console or somewhere on the vehicle, that vibration force is being transmitted up into the shoulder. And think about that posture you go in. You're abducted, internally rotated. And now you have this vibration force coming in. Every time they hit a pothole, what's happening? Compressive force into the shoulder. That can either disrupt healing or create potential pathology. So consider shoulder position with it. For the hands, we want to look at making sure individuals are wearing proper gloves, because gloves, a lot of them have like a silicone in it to help absorb some of the shock for them. Vibration is definitely something to be aware of that you may have to educate yourself on if you're not familiar with the types of tools the individual is using, because it comes into play for return to work, right? We need to educate them. It needs to be a combination of a multidisciplinary approach, maximizing what's available through the employer, us educating the patient, and the employee themselves participating on what will work. It's just like negotiating that home exercise program. We can have the best modifications, but if for some reason that will not work for the employee, they're not going to utilize it. So we need to think of this. And having them be a part of the decision-making process can lead to that sense of empowerment and hit that psychological perspective that we're discussing. As we mentioned with comorbidities, you're going to look at, well, what other resources are available for the individual, if we need to refer them back for any chronic conditions to the physician. And as part of our return to work, we may be looking at determining work capacity. That functional capacity evaluations, is a very specific objective process that some individuals need to go to. I remember back when I was doing industrial rehab, we would have our patients, when they reached the point to return to work, we would simulate for an 8-hour day, work them up to what does their task look like, all the different things they need to do during the day. And I'm using different pieces of equipment to simulate their job roles and take them through a day. That may or may not be something that's available in your area because of reimbursement or funding, but maybe on a smaller scale, we can look at returning the person to work. Do we have an opportunity where we can simulate different activities that our goals are then written, just like we would the patient who has back pain, increasing sitting tolerance or standing tolerance. Well, with our patient that needs to use their hands or their arms, or they need to kneel and bend for a certain period of time, maybe we're writing our goals that they can tolerate those different positions for the appropriate amount of time, have sufficient muscular endurance. And then some patients may need to go for that full functional capacity evaluation, but other things we can get creative in simulating. I remember I was working with an individual who was a fireman. And, you have a sense of firemen are carrying the hoses and it's difficult for them to see and they have all this gear on. Well, we had to work him up. He's going up flights of stairs, carrying these heavy objects. We used a pillowcase with weights in it to simulate this clunky, awkward hose. We started with him using proper mechanics, only carrying about 5 pounds, but we worked our way up to replicating, what that hose might look like. Consider, from a reimbursement perspective, exploring what is available for your patient. That work hardening is a multidisciplinary approach. So that is funded, and coded one specific way. You're looking at, many aspects of return to work. But what some patients may have funding for, if they get to the point where they've achieved their basic goals, but they just don't have that muscular endurance or that activity endurance for return to work, they need more of just the physical conditioning piece of it. Maybe look and see if their reimbursement is available for what's called work conditioning. So it's not work hardening, that's that more complex process that's multidisciplinary, but work conditioning may be something else you can code or bill under. Once they achieve their basic goals, they have the range of motion, the strength, but they're just not physically have the endurance to go back to work. Something else that you can take a look at. And we're going to support this in many ways. We're going to educate our patient on what to do during rest periods. So maybe your plan shifts, or maybe right from the beginning, instead of saying, well, I need you to do this exercise in the morning when you wake up and at night before you go to bed. You know what? That patient that I do education for our cardiovascular technology program. So those are the individuals in the OR doing the cardiac catheterizations with the physician. They're wearing lead that weighs, 20 pounds. So those individuals, I say, you know what? Morning and night, sure, it would be great to stretch them, but when you really need to stretch, we had to come up with a program in between each case, because that vest is rounding you forward, doing forward head posture. Now, because it's pulling anteriorly, it increases the anterior load on your spine. That's why your back is hurting. So what we need to do is posture checks throughout. Every time you take that lead off in between each case, you're giving me 5 chin tucks, and you're doing some, chest expansion. So look at where you're going to incorporate your work rest for the patient to maximize the benefits. How about us? How do we fare in all of this? And what's interesting that the research shows is that a hospital is one of the most hazardous places to work, according to the Bureau of Labor and Statistics, which is somewhat troubling for us, because we're educated on this. We should know better. We are patient care providers. We're educating everyone else, but maybe we're not doing the best job for ourselves. What they have found in the research is that over 90% of facilities have great plans in place to decrease worker injuries. However, they're not effectively implemented. So think about yourselves. Maybe you have that equipment that'll help you lift the patient, but where is it? Oh, it's over there. It's hard to get to, so we'll just do a 2-person lift instead. Is that the best choice? Would you be better off taking the minute to go get the equipment and actually utilize it? So these are some of the things that we're going to ponder, because we put a lot of effort into our patients, that we need to consider ourselves and our own longevity. Those of you who are an outpatient doing a lot of manual work, you need to think about carpal tunnel. Maybe you're young and in your 20s now, but give it 20 years from now, you still want to be doing this, right? And those of us that have been in the profession for a while, you can still use good body mechanics and proper ergonomics to decrease our injuries for ourselves so that we have longevity, right? So we need to model the behaviors that we want our patients to utilize. Musculoskeletal injuries are the leading cause of occupational injury in healthcare. We're looking at the fact that even though we have all this training, that we have a do no harm philosophy, right? We are helpers. That's what brings us to physical and occupational therapy, our athletic trainers. We want to help people. We want to fix them. We want to make it better. And for most of us, right, we're putting that first before anything else. We're skipping lunch to help that patient get back into bed, or you're staying late to squeeze in that patient in outpatient that can't get there until they're done with work, which is great, but what are we doing to our own bodies and ourselves in the process? We may have aches or pains that we're ignoring or disregarding and just pressing through. What the research is saying is we're not working at 100% all the time. And that's physically and maybe cognitively also. Because if we have an underlying pain that we're not giving full attention to, that's going to take its toll on us. And it may impair some of our decision making for our patients. Are we making the best decisions? Because ultimately it can lead to decreased safety and decreased satisfaction, just like we're talking about for other workers. When we look at the hospital setting and the causes of the different injuries, we tend to see that overexertion and body reaction is most common, leading to days away from work. That slips, trips, and falls account for a small portion. So that might be a place where we're going to consider the working environment. If you are, where are the cords lying that someone doesn't trip over it? Are we rushing quickly and maybe the floor is slick and we're slipping? There's been drainage that wasn't cleaned up. Those types of things tend to happen. That's more situational awareness that can improve that. But overexertion and body reaction is where the largest portion of the injuries that require actual days away from work are occurring. And the specific types of injuries that we're seeing are going to be related to those overuse type of pathologies. Over 50% sprains and strains are overuse. We see that this fits with repetitive force, repetitive activities. And if you think about it in healthcare, that's not the first thing that comes to mind, right? That we think about you know, workers on an assembly line or in construction or repetitive, you know, someone working, maybe they're doing lab testing or typing. That's repetitive. What we are doing, is that repetitive? It is, because think about anything that cycles 30 seconds, you're giving a massage. You are guarding a patient with gait training. Your upper body is in kind of a static, ready position, right? Guarding them. Are you thinking about your shoulder? I'm not very tall. I'm 5'2". I should say I used to be 5'2". I'm probably a lot less than that now. When I'm guarding someone who's taller, I suddenly find I'm abducted a lot more to be in the right position and have a good base of support to catch them if they fall. That's not great for my shoulder. I should be thinking about, you know, getting in closer and getting that shoulder down a little bit more. So we need to think about that we do have these risk factors for overuse injuries. And what they've actually found when they break it down even further, that it's not the equipment we're interacting with. It's actually our patients that we're interacting with. 33% of hospital worker injuries that actually cause them to be away from work are caused because of interaction with the patient. Now, it's not that the patient's doing anything wrong. It's not that the clinician is consciously doing anything wrong. And this is all healthcare workers, not just us. But it's when we're interacting with the patient, because again, we're thinking about them first. And the concern here is that if there is burnout in healthcare, in nursing, in therapy, what we tend to see is that loss of our mentors. We lose the individuals who have experience. And that's a brain drain on the profession. That then who's training the next generation? And it does have an impact then on the risk of injuries. If we have our more experienced individuals are the ones leaving maybe before they get hurt, then how does that impact quality of care if we lose that experienced group? So this is an opportunity that we have to look at injury prevention strategies. And it really needs to be multifaceted, that there are components that need to come in. It can't be standardized across everywhere, but we are looking at that the employer is playing a role as well as the employees. We know if we are understaffed, we're rushing, we're doing more, that can increase risk of injury. It leads to fatigue, and then that leads to improper posturing that can lead to cumulative trauma, as well as different pathology developing. When they look at nursing, and the implementation of safe patient handling, right? Those are our key words in healthcare, that these programs, limited lifting, all of these programs go into place, and they've come out of analysis of where injuries are occurring. We're not only seeing needle sticks, but back strain and other musculoskeletal injuries. And these are professions, in nursing in particular, where there is a high stress level. There's an emotional component. So it's all those different risk factors that we spoke about coming into play and linkages to increase injury. Particularly looking at back injuries in the nursing profession, that they, among any profession, they have a higher incidence of back injuries, even more so than in one study I read than miners, truck drivers, agricultural workers, construction workers. Nursing has a greater risk of back injuries. Now, I'm sure you're guessing, why, and maybe mumbling under your breath as to what the reasons are. But a lot of times it relates to patient handling. Again, putting the patient first, not necessarily thinking about ourselves. And body mechanics need to become so second nature that we are using them appropriately. Some facilities are moving to a minimal manual lift environment, so they're using mechanical equipment. The research, it really varies. And I know some of you may be saying, well, I read that it works. And yes, I've read those studies. I've also read the studies. There was one particular study, really long-term longitudinal study. They implemented a minimal manual lift environment, same program in their hospital that was a large hospital, and then in their small community hospital. They did the same thing. They found in the large hospital didn't decrease the risk of injury. In the small community hospital, yes, less injuries. So when we talk about nursing profession, a lot of times they're grouping nurses, aides, everyone into that, and the education needs to trickle all the way down. So the jury is still out on the minimal manual lift, and yes, it can be effective, but the equipment needs to be used appropriately too. And what the research is saying is, yes, that moves us in a positive direction, but a lot of the injuries, so if you think about it, if you lift someone incorrectly, oftentimes if there's a weight shift that's inappropriate, you're going to tear your labrum. You're going to injure your back, herniate a disc. Those are more spontaneous types of injuries. If we look at musculoskeletal disorders in terms of repetitive injury, there are non-lifting contributors to that. It's the other patient handling that's repetitive in nature that's contributing to those injuries. Repositioning a patient, changing the sheets in the awkward posture. It's not necessarily just the lifting that's contributing to the injuries. Donning and doffing the anti-embolism stoppings, the TED hose, if you've ever tried to do that, awkward postures. And again, if we think of the individuals that may be doing some of these things, they are our CNAs, our techs, who are, how much education are they receiving on proper technique? How much follow through do they have? So opportunities we can think of to intervene related to non-lifting also, not just lifting as contributors. What I want to switch to now are us specifically as therapy professionals. How do we fare? Not that it's a competition, but how do we do? And here's what we are guilty of, and I think everyone knows. What happens when you have an ache or pain, or even now, as I feel myself a little uncomfortable, I'm self-diagnosing. I'm deciding what I need to do later to fix that. And what happens is we do a lot of that. We do not take time off. We tend to work through our pain because we know how to fix it. But do we take the time to actually do that? We self-treat a lot. We may not self-treat ourselves through the full course that's necessary to be fully rehabilitated. So we tend to find that this contribution of trying to manage things ourselves adds to the fact that we have limited work productivity. It leads to decreased efficiency in the workplace, specifically looking for ourselves as healthcare professionals. We have something called presenteeism, which means we are at work and we think we're doing the best job that we can. We are physically there, but we are not 100% productive all the time. If we have musculoskeletal pain, often it is going to contribute to the fact that we're somehow limited. We may not even realize it, but we are. And not that we're impairing our patient's recovery, but maybe we're not making the same choices we would if we were at 100% because we didn't have pathology ourselves. Are we maybe not being as thorough in our documentation? But maybe are we kind of rushing things at the end, or our billing is accumulating, or reimbursing for different things is taking a little longer than it should. We tend to cut in the other areas, not necessarily direct patient care. There was a study done in 2012, and some of you may have actually participated in this study. It was a joint venture between APTA and the NOTA, and they looked at the impact on performance of musculoskeletal disorders for us, for therapy clinicians specifically. What we have found is that from the 1,500 respondents in this study, it ranged from individuals in outpatient settings, inpatient settings, home care. It really hit all the different settings that we work in, a variety of degree level, hours worked, years of experience. What they looked at were the various body regions, the rate and frequency of pathology that developed, and also considered the frequency and intensity. And they looked at how much was pain in these different areas impacting the work output for the different individuals, and how did it impact our clinical decision making and judgment. And what they found in this study is that anytime clinicians reported that they had a moderate musculoskeletal disorder, that meant that the ache or pain that resulted in their condition was at least a 4 out of 10 on the visual analog scale, and it either lasted for at least a week, so they had, an episode of a week, or, once a month they had an exacerbation. What they found in physical therapy is that our areas of most pathology were our back. We're doing a lot of lifting, moving, guarding, standing, followed by wrist and hand, neck and shoulder. Interestingly, in OT, they found the back also, followed by neck and then wrist and hand. And for some of you, you may look at that and for OT be wondering or think it's curious that back is first, but OTs, we're all working side by side in direct patient care, in acute care and rehab, and then also occupational therapy is working frequently in the pediatric setting. So you're on the floor, moving around with your patients and clients, doing ADLs in home care with adult clients. A lot of OTs were working in the school setting, so they're down, lifting and moving and getting to the level of their clients. What we found is, in this study, I didn't complete it, but what they found is that all of this different pathology actually led to an 8% decrease in productivity. So that's pretty significant, even though the clinicians may not have realized that there was a decrease. That we do tend to make compensations, as I mentioned, to continue with caseload. We tend to, administratively make changes, cut where we can, but maintain our direct patient care. Again, we need to be cautious of maintaining ourselves so that we can have longevity and be most effective in our interventions. What we're finding in general, particularly in healthcare, some of the studies was looking at the mind-body connection to promote health and well-being between not only physical health, but emotional health to help minimize the risk of injury. And it's those non-biomechanical risk factors that are going to maybe be an opportunity to step in, and then it can be a positive effect for patients. One study looked at nurses, and it was a small cohort, but it was really interesting. What they found is they had the nurses participate in Tai Chi once a week, so they took a class together once a week, and over the time that they followed them, that there was an increase in flexibility for the individuals, that they found that the same individuals, the amount of time that they unscheduled time off that they took before they started taking Tai Chi was greater than the amount of unscheduled time off they took after beginning the Tai Chi. So there was a sense there that they maybe had less physical injury needing time off, and maybe they need a mental health day, so to speak, wasn't needed as often. They also found a decrease in reporting of the fact that the work was limited because of pain or distraction from pain. Other studies have looked at using yoga. Tai Chi kind of fits in with that, but they found that yoga is a way that we can get double benefit, that we are working on the mental as well as the physical piece. The benefit here is that we can increase the response from our parasympathetic system, that through the meditation and the relaxation that can occur during yoga, that it is going to counteract that increased blood pressure, that the adrenaline increase that happens when we're in high stress in healthcare. Or sometimes they even say when you're doing a very monotonous, repetitive task, think of individuals in other work settings, maybe they're in computer technology, where they're performing the same thing over and over. When we do those monotonous tasks, not only does it lead to, repetitive trauma, it can lead to more tension headaches, that there tends to be greater incidence of injuries in workers who are performing repetitive tasks, also because of the psychological piece, because they're focusing so much, or they're not focusing enough on their mechanics because they're focusing on the task. So the yoga can tap into that parasympathetic system to try and combat some of those aspects. They're finding again that this positive interaction can extend to individuals having better coping strategies, that it can be a part of a total wellness program. So for some people, you may be saying, sure, if I could take an hour lunch break every day and go take a yoga class, I would be in a better mood, and yes, I would feel better, in addition to it helping with my posture and alignment. So maybe it creates a little anxiety and stress for some people if you say you should do this, or they know it's available and they can't take advantage of it. But again, that's another place where we can look at stepping in. Maybe there's a balance they can get. One day a week they can try it. Or if it's something they want to try, maybe you can teach them some gentle stretches or repositioning that they can do at their workplace to allow them to function. Your individual who's a delivery worker, can they leave and go to a yoga class? No, because they're making rounds. but can they pull into a parking lot, stop, shut off the vehicle, make sure they're safe, and maybe take 5 minutes to do some stretches or a little meditation that may allow realignment, have, decrease some of those stress hormones and cortisol to have a benefit. Because there's definitely that connection between the musculoskeletal and the mental in many different settings. All of the different injury reduction strategies that we utilize need to be specific to the person. And I mentioned that the first step in this is we have to identify the hazards that the individual is being exposed to. So some of the tools that are available, and again, links to all the different tools that I'm going to discuss in this next section are included on the last page of the notes packet so that you can go to them. And the hazard and caution zone checklists are going to let you take that sheet and have the individual go through it on their own, or you go through it with them to look at common practices. Do they work, maybe they're changing oil on a car. Do I know, are you under the car with your arms above your head, or are you on top of it leaning over into the car? Honestly, I don't know. If I had that worker, maybe having this tool where they go down and they say, well, how many hours a day are you with your hand above your head? And are you using a tool that creates vibration? And how long do you hold this particular static posture? And they go down and they write and they fill it in. It may give you a way to look at what the exacerbating factors are and help you then come up with tasks that you can replicate in the clinic. In terms of mechanics for lifting, there are calculators out there. The expectation of, well, how much should someone be able to lift? If you look at job descriptions for all of us, what does it say? We need to lift, push, pull, and carry at least 50 pounds. Okay. If you work in acute care or neuro rehab, I worked on a spinal cord injury unit. I can tell you I was lifting, pushing, and pulling a lot more than 50 pounds multiple times over the course of the day. So how do we know how much a patient needs to be able to lift and move? Do you know how much concrete blocks weigh? Do you know what position they should be in to decrease the lever arm to make it manageable? We can't be expected to know all this, but there are tools we can utilize to help us better educate our patients. So this tool is really neat. It's from OSHA. And it's a lifting calculator. So what you do it's an app, and I think they have it on the website too. I put the links there. It's really interesting. So what happens is you're going to look at in the app, you go in and you say, okay, well, the patient is, holding their arm at this particular height. They're holding it, 6 inches in front of them. So you check that box. And then you say they're going to lift it to, 6 inches over their shoulder. And you say, well, how much should they safely be able to lift? The calculator is going to calculate it out and tell you how much should they be able to lift and carry. And then you can change that. Well, what if they have to lift it further out in front of them? How much should they be able to lift and carry? So you can objectify it and then figure out when you're goal setting for your patient, not, I need 5 out of 5 upper extremity strength for patient to be able to return to work, stacking, boxes in the warehouse. Well, how heavy are those boxes? Are they stacking potato chips, or are they stacking cases of batteries? Well, this will let you maybe write your goals more specifically to say, okay, well, now they should be able to, at 12 inches in front of them, lift a box that's 20 pounds. That's our short-term goal, but our long-term goal is they need to be able to lift it from 12 inches in front of them to 24 inches over their head, and it has to be 30 pounds. So tools that you can utilize to help you make better decisions for your patients and educate yourself too. Back belts are something that have come up over time as another tool that can be utilized to decrease stress. Those of you that have been in the profession for a while like me, you saw all the rage with the back belt. Everyone everywhere had a back belt. And in some work settings, you still see it. The original intention was, and if you read the research, there were many different reasons everyone thought this was going to be the fix to eliminate back injuries. The idea was that maybe it applies some compressive force to reduce the internal loading on the spine to help decrease the stress on the back, that you're kind of giving an external support to do some of the work. Other research said that, well, you know, it limits forward bending so that we're decreasing that anterior loading, and the person shouldn't be putting themselves in a position where they'll herniate that disc. If you ever put one of these back belts on, number one, it needs to be in the correct place. And when you put it on, it really doesn't limit forward bending. It actually primarily is going to decrease lateral bending, and to some degree it may decrease rotational force. So it really didn't achieve its goal of forward flexion. And what a lot of the research ended up saying is, you know, essentially it's a kinesthetic cue. It's like that soft cervical collar that the person can compress through it if they want, and it needs to be on appropriately. So what they look at is, you know, the research really varies. The studies are all over on the effectiveness of the back belt. And what we need to find is the education still needs to be there, that that's just a cue, it's not a substitute. That, you know, if you have this worker and they're still bending forward, you know, moving the concrete, and they have poor mechanics and this really long lever arm, this person over the course of the day is still going to have pathology if when they go to pull this, you know, trough back, they're pulling with their back instead of weight shifting with a lunge. It really doesn't matter if they have a back belt on. They're still going to put inappropriate force on not only their shoulder but also their back. So like anything, we have to, you know, follow through with the education and make sure that the different tools are accomplishing what they really should be in the workplace. You know, like many of you, I have to bite my tongue a lot when I'm out, because I like to say I can't shut off my therapist when I'm out there just being a regular person. If I'm shopping and I see a worker who maybe is obese and they have that belt kind of strapped above their abdominal tissue, and they're still bending over inappropriately, lifting and twisting and moving, you know, I have to say, you know, it's not my place, but if that was my patient, or if I was looking for an opportunity to work with a facility to develop an education program, I'd probably go look for the manager of that store and offer my services. We often tend to see that we need to be aware of the policies at different work settings, because maybe that employee is obligated to wear the belt and they don't like it for whatever reason. But if we educate them on maybe how it could be helpful if they put it on right and they combine it with proper mechanics, then maybe it can be helpful and they won't have so much negativity towards it and be unbuckling it, so it really isn't accomplishing anything. What we're going to look at are some specific settings. We're going to talk about individuals working in construction. We'll look at grocery stores or department stores, and then we'll discuss farmers. And I picked these specific settings because when we look at some of the tasks, it gives us a good opportunity to kind of expand the ideas to a variety of settings, because you're seeing so many different types of workers out there. And again, we're seeing a lot of do-it-yourselfers. So this will expand to them. Particularly in the construction industry, we're seeing that construction workers are working again until they're later in life, that the median age is increasing, and because of this, they have more chronic disease. They have osteoarthritis, they have increased BMI, diabetes, so they're not going to heal as well. So any injury can take longer for them to heal. And know what kind of construction they're participating in. Do they need heavy endurance because they're out there actually, you know, framing a house? Or are they the worker that's doing a little more manual, you know, screwing and drilling? And sometimes it's as simple as ask them to bring their product in, bring their tool in. I recently needed to have a lock changed at my home. And when the worker came and I'm looking at the drill he had, it was a typical, gun-shaped drill with a static handle. Well, in trying to fit in the small space and hit the face of the lock, and then he had screws on the side of the lock in different areas, he's moving his shoulder and his body all over the place to manipulate this drill. Well, what if the drill, if someone was educating him, which I refrained from, I kept my composure, that what if they had a drill that has an adjustable handle where you can change the grip so that they don't have to have their arm cocked? That, you flip the handle. So sometimes it's straight in, sometimes it's a curved handle, sometimes it's a vertical grip that you change, pistol grip, neutral inline positioning. And maybe look at having the tools altered so that the worker can get in the best positions to help limit the injuries that they're potentially at risk for. Because then this will make their job easier, it'll give them more longevity, and it may be less expensive for the company to buy one tool versus that worker being out on one episode of injury. And sometimes it means you need to have them bring their tools in so you can look at it and figure out how it works and problem solve with them. Contributing factors for our individuals working in construction, we're looking at very physical demands. That what kind of setting are they in? Are you in Arizona and they're out in the heat all the time, or here in southern Florida where we're humid? Are you up north and the construction sites, you have melting snow right now and that worker needs to function? Well, they need to be aware of these different physical demands because our body responds differently. In the heat, we're going to fatigue more quickly. In the cold, we're going to have decreased sensation, decreased response time, so reflexes will be diminished. These are maybe some things to let our patients know about so that we can look at their activities. If you have someone who's doing a lot of overhead work, the pathologies that you want to be aware of, in addition to your rotator cuff pathology or your impingement syndrome, in this positioning, that pec minor, as well as, depending on the neck position, those scalenes can tighten down, leading to thoracic outlet syndrome. So if you're having shoulder pathology or numbness and tingling into the hand, well, pay attention to see, which part of the brachial plexus may be compressed. You may be treating it like a wrist pathology or an elbow cubital tunnel, but maybe it's thoracic outlet. So by understanding the jobs the patient performs, it may lead us to more different special tests we want to perform and different assessment up or down the chain to, again, be more comprehensive in our management of the patient. When we look at individuals who are kneeling, contact pressure can compress the tendons in the sheaths, causing damage. It can decrease circulation to an area. And again, just all that weight bearing and compressive force. So maybe they need to wear knee pads in order to protect that area. We are going to look at not only the lifting and carrying, but the other components. Do you have workers who have to wear a work belt? So whether they're a construction worker with, different tools around their waist, if it's a policeman with his gear belt and his holster, that can create uneven stress on the pelvis that can shift the SI and create compensations in the spine. You can think of if an individual is not opting for a belt and they're just putting things in their pocket, when they do sit down, that can create an uneven positioning of the pelvis that transmits force. So maybe they are in a truck driving and they keep the notepad that they need in their back pocket or their phone or whatever it is. Well, now you're shifting their pelvis, creating a functional scoliosis while they're sitting. Maybe educate them that that's not the best choice for them. Know how heavy things are. Do you know how heavy a cinder block is? I looked it up for you because I wanted to give good examples. One cinder block that's 12 by 16 by 8 weighs about 50 pounds. If you're carrying 1/2 inch 8x8 sheet of plywood, that's greater than 50 pounds. So those are important to recognize because 50 pounds is kind of our mark. Anything going over 50 pounds being lifted and carried is immediately placing someone at a risk. And then combine that with the stature of the individual. Maybe 50 pounds is a significant percentage of their body weight. Slips and falls are something to be aware of because these can create either a spontaneous trauma like a fracture or a sprain, but these can be your near misses where the individual jars themselves, and if that continues to happen over time, then it's a repetitive injury. So with slips and falls, you're thinking of the surface the individual is on. If they, I can tell you, I went and toured a dairy plant, and they packaged milk and ice cream, so it was cold. I happened to be there when they were cleaning all the equipment at the end of the day, and they were then on wet surfaces, also foaming. I didn't realize they literally just foam all of the equipment down. So they're spraying from top all the way down to bottom. The foam is going everywhere, and then they have to hose it off. That places that individual on a very different surface than they were on the whole rest of the day. So now at the end of their shift, they're fatigued and they're on a slippery surface. Maybe my rehab for that individual, if they had that ACL injury, or maybe they had a total joint replacement because they've been doing this job 20 years, is guess what? Let's make sure you have good grips on your shoes. You know you're going to be more unstable, and you have the force of this hose that you're trying to pull and can be, unpredictable. Let's keep your knees a little more flexed. Let's make sure you have some good hip strategies for balance, not just ankle strategies. Maybe you need a good stepping strategy sometimes. So what you can look at, again, modifying our training to fit how the patient is going to be in their environment. NIOSH has a really interesting tool. It's the National Institute for Occupational Safety. It's an app that you download. And I think this is great also for our elderly patients who are out, cleaning their gutters, hanging the holiday lights, putting things up in the attic, things like that. That a ladder stability or ladder instability is where a lot of injury can occur. So you can use this app to tell you what angle the ladder is on, to tell you if it's too steep to safely go up or down. So maybe that's something the individual can utilize. It's twofold. It'll make the ladder placement safe, but it'll also have them pause for a minute, and maybe you could have them do a little stretch or self-awareness or something like that at the time to tap into some of those other factors. Falling debris and materials are something to consider also, because the individuals are going to have to lift more than 50 pounds. We ourselves have to do that. Workers have to do that out at different places. But what you need to think of is there a lifting tool they can utilize to help them? Is there a hand truck available? And then how do they use that hand truck appropriately? Are they working with someone else in a team? Let's say they're putting shingles up on a roof, so they're passing the packages up. Well, yes, this person on the ladder may have done everything correctly, but what about the person they're handing that box of shingles to? If that person drops it, then me down here, I have to shift and accommodate to that. So not only are awkward postures fatiguing, so there's a greater risk of injury, that we have to look for those compensations where there's a rapid shift or tilt to try and accommodate for something. So maybe educating them on lever arms and distances and problem solving, the mechanics of it. Are there braces they can use? If someone's hanging drywall, there's a brace or pieces of equipment that can help hold it up there while they put it in place. Is it an option that's available from their employer that they could utilize? Getting caught between objects is also something that came up for construction workers, that if they are not as familiar with the setting, maybe they're a temporary worker, or they're fatigued, Maybe, as I mentioned, they're out in the cold or the extreme heat, so our reflexes are impaired for different reasons, and they're fatigued. Reaction time is decreased, and they said that a lot of injuries come between getting caught between objects and materials. So obstacle avoidance may be something to add. Looking at, for our patients, maybe surface transitions between different types of surfaces to simulate for them, that they are able to do that with their balance appropriately. As I've mentioned several times today, mental stress comes into play, that particularly in the construction profession, it's high stress profession, so we need to be aware of these patients that that's a component that we might need to consider. Again, might mean an outside referral if they express that to us. If we consider grocery stores as another setting, this may be your individual who works in a grocery store or a warehouse. Maybe online shopping is huge, so maybe they're in a fulfillment center. Or if they, fresh produce delivery, or if they work in a city and they're a delivery person, a lot of times the inside of the trucks are stacked with bins of, let's say, different produce, and then they have to box it up, grab the items, and then take it off the truck to actually deliver it to the different locations. So looking at if they're stocking shelves or working in different areas, you want to rotate the tasks. You don't want to do all your standing activities, then all the kneeling activities. So maybe you're teaching someone as they're loading the cart that they should rotate the height that they're at, so they're not in one posture, or the items that they have to unload or load most frequently should be at, that comfortable height. We'll talk about where the best work zone is for them. I even think of this, like I said, I can't shut off my therapy brain. When I'm being bad, which is pretty often, I'll admit, not managing my comorbidities very well, but, you go to get donuts and you have to say, oh, I'll have, 2 of the frosted and 3 of the chocolate. I'm in my head going, okay, I don't want them to be, lifting overhead to get, 12 donuts from up over here, leading to shoulder fatigue. So when I place my order, silly me, I'll rotate it in the position I think, based on the stature of the individual, is best for their body mechanics. It's crazy, right? What we do. But, if you think this way, you start to see it everywhere, because the common injuries that we're seeing are, like we said, muscle strain, tendinitis, trigger finger because of controlling different objects. Some different tools that you can utilize to, again, give you some insight to their work assessment. I said the caution and hazard zone checklists, but there's also something called the REBA and the RULA. They're not specific to any work environment, so it'll give you broad information of, it's the rapid entire body assessment and the rapid upper limb assessment, and it'll look at what positions are the different joints in, how repetitive are the activities that the individual is performing, and it'll start to give you an idea of where you might want to look for task modification. It gives you an injury risk assessment. Snook tables, for those of you that have patients that you want to dive a little more deeply into this to be really specific in your activity modification and goal setting. The Snook tables are fascinating. They're put out by Liberty Mutual Insurance, and they're utilized by all the different companies to look at data on, every height, weight, size, and gender, individual, the different demographics, and then how long and how much should they be able to lift, reach, stand, every possible task. It gives you ranges as to what's acceptable to be performing without injury. So it looks at risk assessment. So those take some time to go through, but they're really interesting if you want to go through and look at some averages based on actual data as to what can safely be performed. We also have, to be more specific, push-pull calculators. So there are apps that you can put in how much someone, let's say they are in the grocery store, they're taking the produce from the back to the front of the store to deliver it. Well, they have to load that cart, and then they have to push that cart that weighs, 50, 60, 70 pounds over a certain distance. Maybe it's 10 feet, but maybe it's 60 feet. And then how many times a day do they have to repeat that? Because we know doing a lighter, easier activity multiple times can be just as stressful as larger exertions less frequently. So some things to look at when you're calculating the push-pull, the calculators even look at if you're lifting and lowering from what heights, what would be safe to lift and lower. When we consider this, we should look at our carts and our tools that we're utilizing. If you have the opportunity to give feedback, carts that have the horizontal bar to push from, think about that. Everybody is not at the same height where, their shoulders will be relaxed. They'll have a gentle flex in their elbow so they can put their hand on that cart and do a nice lunging walk to use their body weight to push it. For some people, it may be up here if they're 4'11". For other people, if they're 6'3", they may have to bend over to reach that handle. That's not a universal cart for that setting. What would make more sense is to have a cart with a vertical handle. Vertical handles, then everyone can grab it at whatever height is most appropriate for them so they can better maintain their body mechanics. So we want to look at some of these tools let you actually consider what hand height the arm should be at to allow the activity to be safe. If someone's handling cold items, they should be using gloves to help maintain their circulation in their hands, to maintain their dexterity and coordination. If we look at modifications in terms of grip, think of your checkout, your stacking or cleaning shelves. That whenever we use a power grip, we're looking at using the extrinsic muscles of the hand, so that makes more sense versus using a pincer grip. So if someone's scanning different items, sometimes a two-hand hold with a power grip makes more sense than a single hand hold with a pincer type of grip, so that we maximize that. We want to think about contact stress on the hands. Make sure that we are altering it when someone's not squeezing too hard. Again, if they're holding a particular object over time, think of a pricing gun. Now, most of us are digital, but maybe some of you work in more rural, small town areas and they're still using a pricing gun. That's a repetitive stress and a continued grasp. That's muscle fatigue, contact pressure, and it may be vibration depending on how it triggers. So multiple factors that you need to accommodate for there. We know that lifting mechanics is important. We're all very aware of that for our patients, that we don't want them twisting with their objects. I use this worker as an example. This shoulder position is very fatiguing and improper mechanics. That individuals, maybe they just need to look at their work setting to see what's available, because this person filling my paper grocery bag, if you look, there's a shelf there that it can go down on. So a lot of times what I'll do is when I know I'm asking for that paper bag is I'll grab it from the next register because I know right where they are, and I'll open it and put it down on the little shelf for them, just as a little, I guess they probably think I'm a little intrusive, but when I hate seeing them get into this improper mechanics. So I'll open it and I'll put it down on the little shelf, just as little, oh, remember, this is where you should be with it, to try and help out. If you're looking at, well, really, where should the arms be? What is our best work zone? It has been determined. So the position or posture that the extremities should be in that's going to protect the upper extremity is that you can have the area where the individual is looking from going from about heart height down to your waist. So heart height to your waist, and then about the width of your shoulders. This box here is the ideal work zone. And then the distance should be, if you have your elbow flexed, about out to your wrist. So this is your ideal work zone. And sometimes what that means is a worker may need to change the surface, maybe if they can, change where they're putting things. And again, a lot of workplaces, they're not going to let you modify, but at least if you have the conversation with your patient, maybe then if they're obligated to work in not the best position, you can show them how to use the best possible mechanics, talk about task rotation, talk about micro breaks, and look at some, of those other factors. If you can't work in this best zone, the next zone to go out to where it's preferred is if you have to go up to working, kind of within your shoulder height and arm distance out, and then you can go down to your fingertips. So you can kind of expand your box out, and working in this work zone can also be done safely, again, with proper mechanics in order to do so. So maybe you ask the person, if they know they have to put something up high, but they're short, tell them to keep the flex in their elbow, and maybe rather than reaching their arms out, what should they do? They should take a step and lunge so they can maintain their mechanics. So things where communicating with our patients will allow us to be effective in exploring some of these things, or at least trying to make improvements where we can. We know we can't get it all perfect. If you're looking at someone who's a cashier, go with some obvious things. Anti-fatigue mats in many settings are great, to absorb some shock. Have someone weight shift, put their foot up on a ledge or on a stool or see something to rest it on. Make sure scanners are clean so that they don't have to use as much force and cock their wrists as much to move the objects. Look at your small details too. Let's just say someone's working in a bakery and they have to fill a big tray. If that tray is lengthwise, so let's say my tray, here's my tray, I put it this way, I have to reach all the way over to fill this. That throws off my mechanics. Can't I just position my tray like this and now I'm in my better work zone? So maybe there are small tasks that someone can change in order to rearrange things to make it a little easier for them. If you're thinking about looking at plants that someone's working in, let's say they're in a meat packing plant or a food production plant, they're going to have safety measures in place in order to accommodate individuals for exposure to different chemicals and things of that nature. What we want to be attentive to looking at are considering vibration force that they may be exposed to. So this is in plants, looking at automobile, if they're, taking the nuts or whatever they're called off the tires, to dental clinicians, nail salons. As I said, people working with small tools, look at the vibration. Having a glove with a particular silicone fabric in it is going to allow some absorption of that shock. Just a typical leather glove is not going to accomplish that. So look at the hand grips on different tools. Hand grips should be in place so that they are not placing excessive pressure in the palm of the hand, that the grip shouldn't end before the palm. It should extend out past the palm so that there's no pressure. And if someone's cutting, their force should be directly down. So when you go directly down, then you're going to be able to use body mechanics more as opposed to just wrist and awkward posture. If someone's doing cutting, if they're in food prep, or they're a chef, or they're in a poultry plant or something of that nature. Use the tool that's designed so that you're going perpendicular so that you can exert the appropriate force. Carpal tunnel is a pathology that we're being cautious of because we are looking at excessive wrist flexion. So in individuals who are working in a lab, maybe they're on a microscope, watch that excessive wrist flexion. Someone who's doing a lot of wrapping or packing of items, be aware of this, that we don't want too much wrist flexion for them. And when they're holding different grip objects, look for a pistol grip. A pistol grip is going to give more of a cylindrical grip versus something that you have to trigger with your finger. So they actually make attachments that can go onto spray cans to make it a pistol grip as opposed to a trigger. Look for tools that have a spring in the mechanism so the force is exerted to close the tool, and then when they release, it'll open back up itself. So this makes it a little easier for the individual. Some may let you adjust the tension even so that they don't have to open and close the object. Table height is something additional that you're going to consider. For individuals who are on an assembly line, if you're doing something where they have to look very closely at objects, we don't want to fall into that forward head posture, that rounded shoulders, tightening up that pec minor. So maybe a table that tilts up. If someone is in CAD, or computer engineering or architectural design. I was speaking with someone whose son is a submariner. He's plotting graphs on a submarine. So he needed a table that tilted up so he's not like this all the time. So different ways that we can employ this. If you need dexterity or focus on something, you want it a little bit lower. And again, look at your table heights for your individual, and then consider when you tell someone what height to put it on, if they're a packer, think about the box because that'll add to the height there. Conveyor belts. What I want you to think about that is they're obligated to go at the rate of the belt. So that might be something that you need to simulate in your return to work activity, that their coordination and speed and muscle endurance is up to the speed that they have to be functioning at. So not only can they reach it, but can they actually function repetitively with proper mechanics at the particular rate that they need to function. We mentioned carts, that you want to look at the handle of it, but you also want to think about the wheels. The type of wheels is going to make a difference as to how easily it moves across the surface. So we want to be aware that solid hard wheels are good for concrete or hard surfaces if the individual is working, let's say in a factory on the floor. So that same hand track that they may be utilizing inside with hard wheels isn't the one that they want to take out on their deliveries when they have to go down the slick ramp in the rain, across the gravel to get to, the back entrance of that restaurant. Pneumatic wheels are going to be better for those rough surfaces, and then they have to check the pressure in them to make sure they're inflated. So think of some of the things you may consider with your wheelchairs, what type of tires you're going to put on it based on the surfaces. That may apply to the carts that an individual is using. if we look at the farming setting, farmers are at a greater risk of pathologies. The pathology that they say commonly occurs is hip replacement. 1 in 5 farmers need a hip replacement. They're working until later in life. They're very traditionally using the same techniques that have always been utilized, but they're trying to move forward with technology. It tends to be kind of like a hereditary, right, type of profession, which is great, but we want to preserve them for us. So what we're going to consider is, again, look at the grips that they're using. Big tasks we know, lifting, moving, we know how to educate on that, but I want you to think about the smaller tasks too. Look at the harvest bins that they're utilizing. Does it have a cutout in the handle so that you can grab it appropriately? Or do they have to use a pincer grasp that is not helpful? What kind of farmer are they? If they're working with livestock, we tend to see that individuals have more upper extremity pathology in farmers who are pig and dairy farmers because the livestock is unpredictable and the techniques that they're performing are different. So we're going to be aware of that in our education. Even if it's that lower extremity patient, they had that total joint replacement, they had that total hip replacement. You've done everything to educate them on that total hip. But if you don't talk to them about, well, what are their arms doing as they're trying to balance, that may change your training activity. If you've just been doing BAPS board, standing balance, compliant surface, but they're going to have a big cow or a big pig they're bending down trying to control, you need to be doing a little more prompting in your balance training. Think about those things. Think about these individuals on the harvest machines, on the tractors, that vibration exposure for them, things to think about. Do they need a cushion on their seat? Be aware of all of these aspects. And then think about, as we're looking at the fact that for all of these individuals, we are changing what they're doing. We are coming in and we're offering suggestions that we think are fabulous and can help them, but we're trying to make a change and they're thinking about their employer too. So we have to be aware of that, particularly with the farming where it is, kind of traditional in how they work. So we have to be aware of doing these things gently, being a partner with our patient in implementing our changes, and know that if we make minor changes, it can really have a nice positive impact on our patients. So from day one, think about assessing some of these things. Number one, because it's probably what's most important to your patient, right? Decreasing their pain and getting them back to whatever they need to do, which a lot of times may be work. Think about it from the beginning because it can really guide your interventions and your care for your patient. So lots of ways you've learned today that we can step in and look at not only the biomechanics of the workplace, but I wanted to spend time to have you look at the big picture and look at some of the other resources that are there so that it can assist you. What we're going to do next, I know there were a bunch of questions. I apologize, I couldn't read them because I was speaking. Something about the images. On many of the slides for the images, I did put the website that they came from so that you can, pull that link and go back to them. All of the links for many of the tools are on the last page of the course notes. And then OSHA. Most of the images are from the OSHA website if you go to that. But if you still have questions, just email me and I'm happy to provide you with the links. Legally, I really can't give out the pictures because they're not mine to let you duplicate. But OSHA really has a lot of this out there. They have specific tools for almost every work setting, and it takes you down a laundry list of what to look at. Okay?